Concepts in Refractive Surgery. Part 2. Clinical Examples. Before we start with the clinical examples, let us go quickly through the checklist. The checklist consists of 5 items. The first one is refractive error. After we measure the refractive error, we can determine what options are most suitable in the algorithm. Number 2, mesopic pupil. We have to measure the mesopic pupil in order to determine the optical zone. Number 3, K readings. They are important in order to avoid flap complications and also for the calculations of treatment. Number 4, percent tissue altered, the PTA. The PTA is critical in the calculations for LASIK in order to let the LASIK on the safe side. Number 5 is pupil offset. It is very important when we have plus component in the refractive error or minus astigmatism higher than -2. Clinical examples. Case number 1. A patient has -4 diopters sphere. His mesopic pupil is 5.70 millimeters and his corneal thickness is 520 microns. According to the algorithm, we have 2 options: surface ablation, like PRK, and lamellar ablation, like LASIK. Starting with the PRK, there are 3 conditions to go for PRK. The pre-op corneal thickness should be at least 470. The final corneal thickness after the operation should be at least 400 microns, and the optical zone should be at least 6 millimeters. In regard with the mesopic pupil, if we simply add 0.5 millimeter to the mesopic pupil, the optical zone will be 6.2 millimeter, and accordingly, the ablation depth will be 56 microns, and the final corneal thickness will be 464 microns. So PRK is accepted. LASIK. 2 conditions for LASIK. The pre-op corneal thickness should be at least 470 microns, and the optical zone should be at least 6 millimeters. For the 6.2 millimeter of optical zone, the ablation depth will be 55 microns. Now, we have to calculate the PTA. The PTA for a flap thickness of 130 microns will be less than 40%, and it will be acceptable, and the residual stromal bed is higher than 300 microns. To study the effect of the correction of -4 diopters on the flat K, the flat K will be reduced to be 41.8, which is higher than 34 diopters, so LASIK is also accepted. So we can go for PRK and we can go for LASIK for a flap thickness of 130 microns. Case number 2. A patient has -7 diopters sphere. His mesopic pupil is 5.9 millimeters and his pre-op corneal thickness is 530 microns. According to the algorithm, we have 3 options: surface ablation, like PRK, lamellar ablation, like LASIK, and phakic IOL. Starting with the PRK. Adding 0.5 millimeter to the mesopic pupil, the optical zone will be 6.4 millimeter, and the ablation depth will be 103 microns. Accordingly, the final corneal thickness will be 427 microns. So PRK is accepted. LASIK. For an optical zone of 6.4 millimeter, the ablation depth will be 107 microns. And if we calculate the PTA for a flap thickness of 120 microns, it will be above 40%, which is not acceptable, although the residual stromal bed is 333 microns. And if we reduce the flap thickness to be 110, still the PTA is above 40%, although the residual stromal bed is 313. But if we make the flap thickness to be 100 microns, then the PTA will be accepted and the residual stromal bed will be 323 microns. To study the effect of this correction on the K readings, assuming that the flat K of the patient is 43 diopters, the -7 diopter correction will reduce the flat K to be 37.4 diopters, which is above 34, and LASIK is accepted. Regarding phakic IOL option, we have to look at the anterior chamber depth, and this patient has a very good anterior chamber depth. Therefore, we can go for PRK, LASIK, and phakic IOL in this patient, but when the option is LASIK, the flap thickness should be 100 microns. Case number 3. A patient has -6 diopters sphere, -2 diopters cylinder. His mesopic pupil is 5.25 millimeters, and his pre-op corneal thickness is 550 microns. According to the algorithm, we have 3 options: surface ablation like PRK, lamellar ablation like LASIK, and phakic IOL. Starting with the PRK. If we simply add 0.5 millimeter to the mesopic pupil for an optical zone to be 5.75, this is not accepted because it is below 6 millimeter. And if we adjust the optical zone to be 6 millimeter, the ablation depth will be 105 microns, and the final corneal thickness will be 445 microns, and PRK will be accepted. If the option is LASIK, for an optical zone of 6 millimeter, the ablation depth will be 102 microns, and the PTA for a flap thickness of 100 microns will be 36.7%, which is accepted. Now, since it is below 40%, we can increase the thickness of the flap to be 110, and still the PTA is below 40%. Now, we gain this 10 microns in the flap thickness in order to have a thicker flap to avoid some flap complications intra and post-operatively. To study the effect of this correction on the K readings, we assume that the flat K of this patient is 41 diopters. -6 diopters correction will reduce the flat K to be 36.2 diopters, which is above 34 diopters. So it is accepted. But we have to pay attention to the -2 diopters of astigmatism in order to adjust the pupil offset. So we look at the XY coordinates of pupil center. We take half the values, input these values into pupil offset in order to decenter the ablation profile, but don't forget to decenter also flap creation. For phakic IOL option, we look at the anterior chamber depth of this patient. We will find that it is below 3 millimeter, so it is forbidden. So in case number 3, we have 2 options, PRK or LASIK, but for LASIK, the flap thickness can be 100 or 110 microns, but we have to adjust pupil offset in order to avoid post-operative high-order aberrations, especially coma. Case number 4. A patient has mixed astigmatism, +1 diopters sphere, -3 diopters cylinder. His mesopic pupil is 5.5 millimeters, and his pre-op corneal thickness is 480 microns. According to the algorithm, he has mixed astigmatism, and we have 2 options, LASIK and phakic IOL. starting with LASIK. Two conditions for LASIK in this case: the pre-op corneal thickness should be at least 470 microns, and the optical zone should be at least 7 millimeter. So if we simply add 0.5 millimeter to the mesopic pupil, we will have an optical zone of 6 millimeter, which is not accepted because it is mixed astigmatism. Therefore, we have to go for 7 millimeter optical zone, and the ablation depth will be 39 microns. Now, there is another way to calculate the ablation depth in this case. We have to convert this equation to make it the sphere should be minus and the cylinder should be plus, and then we can apply the formula on the minus component in this equation, as you see here, and the ablation depth will be roughly 33 microns. Also, there is another way to calculate the ablation depth. We have said that the optical zone is 7 millimeter, and for 7 millimeter optical zone, each 1 diopter of correction, the ablation depth will be 17 microns. So we can multiply 17 microns by 2 diopters of correction, and the ablation depth will be 34 microns. So as you see, there are 3 methods to calculate ablation depth in this way, or in this case. Now, the PTA, in this case, for a flap thickness of 130 microns, will be 35%, which is accepted. Now, to study the effect of this correction on the K readings, we have to discuss some concepts of corneal astigmatism. Now, corneal astigmatism is the distance between the flat and the steep axis, as you see here. Now, the -3 diopters correction of astigmatism means that we are going to flatten the steep axis to approach the flat axis. And after that, the +1 correction will increase both axes. In other words, if we assume that the steep K reading of the patient is 43 diopters and the flat K reading is 40.6 diopters, the -3 correction will reduce 43 to be 40.6, and then the +1 will increase both. To apply this on the numbers, -3 will affect the steep K and will reduce it to be 40.6 diopters. Then +1 will affect both in order to increase them to be 41.8 diopters. And the final K reading, 41.8 diopters, is within the accepted range, which is between 34 and 49 diopters. So this is the way how to calculate the effect of mixed astigmatism correction on K readings. Now, since the case is mixed astigmatism, we have a plus component, and in addition to this, we have above -2 cylinder, so we have to consider offset pupil. So we input half X and Y coordinate values. We have to input them in the machine in order to decenter the ablation profile, and don't forget to decenter also flap creation. For the phakic IOL option, we look at the anterior chamber depth and we find it very good. So in this case, we can go for LASIK for a flap thickness of 130 but with pupil offset adjustment, and we can go also for phakic IOL implantation. Case number 5. A patient has +4 diopters sphere. his mesopic pupil is 6 millimeters, and his pre-op corneal thickness is 540 microns. According to the algorithm, since it is borderline, we can go for LASIK, phakic IOL, or refractive lens exchange, or what we call it clear lens extraction. Starting with LASIK, two conditions for LASIK here. Pre-op corneal thickness should be at least 470 microns, and the optical zone should be at least 7 millimeter. Now, for an optical zone of 7 millimeter, the ablation depth is 0. Why? Because it is a hyperopic profile, and in the hyperopic profile, the ablation will be at the periphery or the mid-periphery of the cornea, while in the center of the cornea, there will be no ablation. But still, we have to calculate the PTA. The PTA for a flap thickness of 130 microns is 24%. Now, the K readings here to be considered is Kmax, because it is hyperopia. Now, the Kmax will be increased by the +4 diopters correction to be 51.5 diopters, which is above the accepted limit. So LASIK cannot be applied. Now we have phakic IOL, or clear lens extraction, or refractive lens exchange. First, we have to look at anterior chamber depth. The anterior chamber depth is good, so we can go for phakic IOL if the age of the patient is below 40. Otherwise, we can go for refractive lens exchange. Case number 6. A patient has -6 diopters, his mesopic pupil is 5 millimeter, his pre-op corneal thickness is 530 microns. According to the algorithm, we have 3 options: PRK, LASIK, and phakic IOL. Starting with PRK. The optical zone should be at least 6 millimeter, and accordingly, the ablation depth will be 80 microns, and the final corneal thickness will be 460 microns. So, PRK is accepted. LASIK. For an optical zone of 6 millimeter, the ablation depth is 78 microns, and the PTA will be 39% if the flap thickness is 130, and if we reduce the flap thickness to be 100, then the PTA will be 33.5%. And in this case, we can gain a larger optical zone, because if we increase the ablation depth by increasing the optical zone to be 6.30 microns, the ablation depth will be 89 microns. And if we apply that, the PTA for 100 microns flap thickness will still be accepted. So in this case, by reducing the flap thickness, we gained a larger optical zone in order to give the patient better quality of vision, especially that his refractive error -6 may reduce the what we call the efficient pupil, the efficient optical zone. The efficient optical zone is the post-op optical zone, or the real optical zone, which is smaller than the assumed optical zone, especially with high error corrections. So if we gain more optical zone, it will be much better. To study the effect of this correction on the K readings, we assume that the flat K of the patient is 38. Now, the 38 will be reduced to be 33.2, which is less than 34, so we cannot go for PRK or for LASIK. Both are forbidden. So the last option is phakic IOL. Unfortunately, the patient has an anterior chamber depth below the accepted limit, so we cannot go also for phakic IOL. So in this case, keratorefractive procedures cannot be done. Phakic IOL is contraindicated. But what about clear lens extraction? Although clear lens extraction, this option is not mentioned in the algorithm for such refractive error, but we can do it in special cases. But in this case, we have to look at patient's age. Unfortunately, the patient is 25-year-old, so we cannot go for clear lens extraction as well. To sum up, measure the refractive error, measure the mesopic pupil, consider K readings, calculate percent tissue altered, and take care of pupil offset in some circumstances. Don't do phaco-KOL when the anterior chamber depth is less than 3 mm. Don't do it for patients older than 40 years old. Don't do clear lens extraction for patients younger than 40 years old. Don't go for an optical zone less than 6 mm in keratorefractive procedures. Don't go for keratorefractive procedures when pre-op corneal thickness is below 470 microns. Don't do PRK if the final corneal thickness is below 400 microns. And if you want to do LASIK, the optical zone should be at least 7 mm if you have any plus component in the refractive error. This is the end of part 2. In part number 3, I will go through a very important topic, which is the difference between manifest and tomographic astigmatism, and I will discuss the 9 probabilities of this situation and how to deal with them. Thank you very much.